Well, you've had the immense good sense to give up every other event and come to this breakfast this morning. This is by far the best breakfast you will come to all week in New York. So congratulations. Now, we have had fine introductions, but we need to really focus in the next 25 minutes or so on what are we going to do differently when we leave this room. Great breakfast, fabulous, but we need to change. And why do we need to change? Because what we're doing currently is not working fast enough. In one analysis that was completed by the Institute of Health Metrics and Evaluation in Seattle, the new Center of Global Health, only 4 countries out of 75 priority countries are going to reach MDG 5 by 2015. Only 4 countries. Now, that is an abomination. Despite all of the great work that you do and many others do, we are just not getting it right. So we need to pause, we need to step back, and we need to honestly ask ourselves what has worked, what hasn't worked, and when we leave this breakfast room this morning, what are we going to pledge to do differently? And this panel are going to give you the answers.
For me, the interventions that work are the interventions that has reached the most underserved, which has reached the poorest and reached the most vulnerable. Your interventions will not work till we reach that last mile. The second point I want to make is wherever interventions have worked, it's an example of integrated approach. So just technical interventions are good, but won't take us the whole way. So what are we doing to put the technical interventions in place? What are we doing to generate demand? What are we doing at the community level? Are we adopting a rights-based approach? HR, is it in place? So I would root for integrated interventions, and I'm not very sure I can name a country which has successfully reduced MDG 5, but in June we heard about Malawi, and yesterday we heard about Niger, which has brought about great, kind of difference in child survival. And if you look at both the models, it is an integrated approach because they've worked at community level, they've worked at systems, they've worked at governance and creation of political will. So those are my 2 points.
Fabulous. Thank you very much. Ariel.
Well, wonderful, right, to build on those 2 key points. But if I had to choose a particular technical intervention, I would go with family planning. I think fertility declines have been key to the success that we are now accounting in global health in terms of the reduction in maternal mortality and women's dying. And Bangladesh is one of the countries that actually will meet the MDGs in this regard, and where there's been almost 40% decline in maternal mortality over the last, or number of maternal deaths in the last decade, and half of that gain was due to fertility decline. So I would say that's key for our efforts. Of course, many other things as we heard before, but postpartum hemorrhage and preeclampsia, eclampsia are key, and I think the UN Commission on Commodities will help us ensure that the last mile has all of the supplies for well-trained skilled birth attendants to really deliver those and save more lives.
So we shouldn't be reinventing the wheel. We know what works, we just need to scale it up. But lastly, and I would like to take your point about inequity and getting to the last mile. 2 weeks ago, I was in Somalia, and Somalia is one of the countries with the highest maternal mortality. And we can see in Somalia why we are having the highest maternal mortality. We are having basically 8th grade girl having too many pregnancies, too often, and too soon. And you mentioned family planning. The organization I'm working for, the United Nations Population Fund, wants to make sure that every pregnancy is wanted, that every birth is safe, and every young person potential is achieved. And I think if we take this approach, we will achieve greater reduction of maternal mortality.
The trick right now is to translate everything that is happening at the global level, the pledges, the promises, the policies. Now I think whether it's civil society or everybody else, I think our job right now is to really hold people who make the promises to account. How are we ensuring that the woman and the child and the family for whom these pledges are being made, they are being actually held to account? I mean, for a moment, let's forget that we are experts in our own field. Let's say you're a man, I'm a woman, about to give birth in a village. Do I care about whether my country is going to reach MDG 5? I don't. Am I interested in a percentage drop in MMR? No. What I want to do is, I don't want to die while giving birth to my child. So how do we bring that feeling, and how do we reconcile to the MDG 5 targets and this target and that target? I think, and civil society, along with other what we call intermediaries, elected representatives, media, the corporate sector, I think all of us need to really now put our heads together and think, yes, lots of good policies, promises, how do we hold them to account?
We are now seeing countries themselves taking increasingly responsibility and accountability and funding of their own health problems, so that, in fact, USAID may very well be graduating programs. We have been graduating programs in many successful countries in Latin America, Central Europe, and now Asia. So we see that. It's a story of success, of great accomplishments, and greater country ownership. As I tell my colleagues in the NGOs, we now need to really shift the canon of advocacy to the local governments. They now have more resources, and people are spending out of pocket, as you know, and that's not the way to finance health. Governments will need to step up the plate far more than they have in the past. And this is happening, and so I'm optimistic about the resourcing for maternal child health, but with a different equation in the future.
So one big opportunity that I see that will have a major impact on saving women's lives is what happened at the clinic level. I just visited recently Mozambique, and the government there is committed to what they call humanization of care. One of the major reasons why women, it's not just cost, it's not just cultural, why women are not going to deliver in a facility is because they feel that they are not treated properly or respectfully. And what Mozambique is doing is that women are coming with their husband, with their in-laws. They can deliver any way they want. They can stand up, they can sit, they can lay down. So it's really an atmosphere that is being created through which women are delivering with respect, yeah, and with being properly treated by providers. And because of that, there is a word of mouth. And what we have seen is we have seen an uptake in deliveries at facility in Mozambique, not because there was the government was providing funding for the delivery, but because of how we have changed the way we provide services.
So we've been hearing this morning about where we are now, what's working, and what we want to do with this second panel is talk about what does it take to bring this to the next level. Is it a matter of taking what's currently being done and expanding on it, or to achieve the MDG goals? Is it going to take something more? So it's my privilege to facilitate a conversation among our panelists, but also with you, the audience. I'm no expert in maternal child health, and so I'm going to be playing the role that I currently play of the journalist moderator, which is a lot of fun, actually. So the first question for all of our panelists is really a big one, and I'm going to ask them to keep it short so that we have time for the rest of the program. But it's, what are the big unsolved challenges in maternal health? And I'll go down the line on this, and I'll use the moderator's prerogative of cutting you off if it goes way too long. So Robert, why don't you take it first?
Okay, thanks, Rich. And first, thanks to the organizers for this session. It's really great to be with all of you. I think there's some real obvious challenges. We have access issues, we have human resource issues, we have issues of really coming up with the evidence to convince donors and the champions really for our cause. But I'd like to focus really on an issue which I don't think gets as much attention, and that is how we link this all together. We heard a bit about family planning and its importance for maternal health. HIV/AIDS obviously is killing a lot of women in Africa. It needs to be linked in with our work. But also beyond just the health sector, we need to be looking at issues such as education, School education, we know, is very important for women. Economic empowerment, having the resources so that they can actually deal with some of the issues in their lives, and then gender issues. And these are all, I think, issues that we at USAID as a development agency really try to bring together. And we've done some of this, and I think some countries are better than others, but we have a long ways to go. And I think the HIV/AIDS community has shown us how we can look at this much more as a multi-sectoral approach, because it does affect all of our programs.
What is important in country, in Indonesia, is that we look at access to water and sanitation as one of the major drivers that will bring down maternal mortality rate. We need to ensure that each community health centers down in community level have access to clean water and sanitation and energy, electricity, 24 hours, the whole 24 hours. That will drive down maternal mortality rate by far.
Maternal mortality seems like it's a medical diagnosis. And we've heard that it's actually more than one medical diagnosis. There are several problems, but that's actually not the reality. The reality is it's much more than a medical diagnosis. As we've been hearing, it's a convergence of social, economic, cultural, infrastructure factors, all of which kind of converge to create the problem of putting a woman at risk at the time of delivery of a child or during pregnancy. And so the solutions for that kind of very complicated problem is going to require a new kind of collaboration and cooperation that we haven't had before. And we're going to have to break down the barriers that have stood between us, between for-profit companies, governments, NGOs, et cetera. If we're really going to lick this problem, we're going to have to shed a lot of what's interfered with our working together and have really meaningful partnerships to address this problem.
But I think going forward, we're not going to have individual interventions that are going to radically change what we do and how we achieve. I think what we need is putting those interventions together, strengthening the health system, and going forward looking at a broad array of things. For me, what I think is going to be the game changer going forward is quality of care, because we have the potential before us for a generational shift in women's thinking about the place of birth. There are a number of initiatives globally, the JSY scheme in India, the Health Equity Fund in Cambodia, that have really increased utilization of health services. But the problem is right now, women are not yet seeing the added value of going to a facility. They don't necessarily benefit from the quality of care that they need when they get to the facility. So the past generation's norm was deliver at home. We'll only get the next generation's norm to be deliver in a facility if we can provide them with good quality care and make it worth their while to come. That's why when Alain was talking about the work that we've done in Mozambique to improve humanization of care and improve quality of care, those things are fundamentally important as well. As much as the incentives for promoting institutional birth, we also have to make it worth women's while.